Hi, my name is Jordan Jeffrey and I am a speech pathologist. I work at John Hunter Hospital in Newcastle, Australia, and am an affiliate of the Hunter Medical Research Institute in Newcastle and the Centre of Research Excellence in Treatable Traits. This presentation aligns with the accompanying document titled Speech Pathology Treatment Guide for Patients with Co-occurring Asthma and Laryngeal Dysfunction, which is also linked on this website. All references for the information discussed in this presentation can be found in this document. Our aim in providing this presentation and its associated document is to further educate speech pathologists on asthma in general, as well as the recommended approaches for speech pathology, assessment and treatment of patients who have laryngeal dysfunction and co-occurring asthma. Laryngeal dysfunction is an umbrella term to describe disorders of laryngeal function that include inducible laryngeal obstruction, also known as vocal cord dysfunction, disorders of laryngeal muscle tension, such as muscle tension dysphonia and functional dysphagia, laryngeal paresthesia or globus, chronic cough, specifically allotussia and hypotussia, and dysphonia. Asthma affects 2.8 million Australians and is the leading cause of burden of disease in children. In 2020 to 2021, asthma was the primary diagnosis of approximately 25,000 hospital admissions in Australia. Currently, there is no known single diagnostic test for asthma, and people with asthma often experience their symptoms at night, early in the morning, or after activity. Asthma ranges in severity, and asthma exacerbations can develop within a few minutes or more slowly over hours, days, or even weeks. There is no known cure for asthma, but it can be managed and treated. Asthma is a chronic inflammatory condition of the small airways. People with asthma experience airflow obstruction, which means they find it more difficult to exhale. Bronchial hyperresponsiveness is a key feature of asthma. The airways of a person with asthma are more sensitive to various stimuli, and when they are exposed to a known trigger, the airways narrow, resulting in shortness of breath, cough, wheeze, or chest tightness. This narrowing can be a result of bronchial wall inflammation, smooth muscle contraction, or mucus hypersecretion, or a combination of all of these. Patients with asthma may also experience a loss of recoil in the elastic tissues, which means that they are unable to exhale all the air in their lungs, known as gas or air trapping. This can lead to lung overinflation and shortness of breath. Asthma symptoms are reversible if treated appropriately. However, over time, if not treated optimally, the smooth muscles of the airway can become fibrotic and scar. The membranes thicken permanently, which is termed airway remodeling, and this is not reversible. The cause of asthma is largely unknown. What we do know is that the strongest risk factors are genetic and environmental. In patients with asthma, the airways are more sensitive to triggers. Triggers for asthma may include viral respiratory infections, allergens, smoke and air pollution, chemical irritants, and strong odours. These cross over with triggers of upper airway dysfunction, such as cough, hypersensitivity, or ILO. There is significant symptom overlap between laryngeal dysfunction and asthma, and because of this, patients may be misdiagnosed as having refractory asthma. The table on this slide details how the presentation of these two diagnoses overlap. Patients with co-occurring asthma and laryngeal dysfunction have an increased symptom burden, which can lead to increased healthcare costs, inappropriate medical treatment, and poor adherence to medical and behavioural intervention, such as speech pathology treatment. Their diagnostic process can be disjointed, and they can feel frustrated at the time taken for the diagnosis and misunderstanding of their symptoms. While speech pathologists are familiar with laryngeal dysfunction disorders, they may need to employ a different approach for patients with coexisting asthma and laryngeal dysfunction. Dysfunctional breathing, also known as breathing pattern disorder, is defined as an altered pattern of breathing which could be structural, functional, or have no organic cause, and results in symptoms that might be chronic or intermittent for the patient. Dysfunctional breathing can co-occur with asthma, inducible laryngeal obstruction, and chronic cough. It is thought that up to 80% of asthma patients may also have dysfunctional breathing. However, it should be noted that numbers vary greatly in the literature. Dysfunctional breathing may be attributed to an atypical location, such as thoracic or clavicular breathing, abnormal rate, abnormal route, such as oral breathing, or features such as stridor or breath holding. These may present on their own or in combination. As you can imagine, there is an overlap in symptoms between dysfunctional breathing and ILO, and further research is required to investigate the nature of this relationship. It is important to address dysfunctional breathing characteristics identified during assessment as part of a comprehensive speech pathology management. Now we will talk more in detail about diagnosis of asthma. Asthma diagnosis has moved away from a one-size-fits-all approach and is thought of more as an umbrella diagnosis that encompasses many phenotypes and endotypes with varied symptoms and treatment profiles. Endotypes refer to clusters of biomarkers, which we will describe in more detail on the following slides. One of the major advances in treatment of asthma is the recognition that patients with certain endotypes benefit from biologic therapies, also called monoclonals. These are currently available on the PBS for severe asthma, although patients must meet strict requirements to be eligible. Phenotypes are observable characteristics that can eventuate from combined hereditary or environmental factors such as obesity. Phenotypes may change over time and co-occur. The recognition of asthma phenotypes and endotypes has led to major advancements in the introduction of personalised asthma treatment. Patients are assessed to determine the drivers of their asthma, including the different contributing factors to their asthma, which can be pulmonary, extrapulmonary, or behavioural. These are known as treatable traits. Speech pathology management of a patient with asthma can be impacted by the type of asthma the patient has. Asthma can be subtyped by driving endotypes, presentations, or clinical course. Asthma phenotypes can be broadly categorised into two main types of asthma, type 2 high and type 2 low. On this slide are just some of the most common asthma subtypes and presentations. Presentations and clinical course may co-occur. Biomarkers are measurable entities that provide insight into specific drivers of asthma and treatments that are most likely to be effective. Biomarkers currently in widespread use clinically include blood eosinophil count, fraction of exhaled nitric oxide or FeNO, immunoglobulin E, also known as IgE, and IgE levels when exposed to specific allergens. The clinical identification of biomarkers allows for recognition of different asthma phenotypes, identifying those at higher risk of asthma attacks, and the provision of personalised treatment options. Eosinophils are a subtype of white blood cells found in the bone marrow. Blood eosinophils are easily measured through a full blood count, a commonly ordered blood test. They strongly indicate which patients will have more asthma attacks, a faster decline in lung function, and benefit from corticosteroids and biologic therapies. Sputum eosinophils and neutrophils, both white blood cells, are observed in a patient's sputum sample and expressed as a percentage of total cells. Their presence indicates that the patient might respond well to a particular biologic treatment. This test is time-consuming, often poorly tolerated by patients, and requires specialist staff trained in processing and analysis of samples. Therefore, it is typically unavailable outside of specialist centres and research settings. The FeNO test is a non-invasive test performed by using a small portable device that measures the level of nitric oxide in an exhaled breath in parts per billion. FeNO levels increase as inflammation increases. FeNO detects patients with type 2 driven airway inflammation and indicates those most likely to benefit from inhaled corticosteroids. FeNO levels may provide information as to whether a patient is adhering to their prescribed inhaled corticosteroid regime and can be valuable in considering inhaled corticosteroid treatment requirements. FeNO levels can be influenced by external variables such as air quality, smoking, sinus disease, diet, obesity, virus and infections, which all need to be considered when interpreting the results. IgE is an antibody found in the blood. When a person is exposed to an allergen, such as pollen, dust mites, cat or dog dander, an allergic reaction is initiated. Allergen-specific IgE antibodies are produced. The IgE antibodies circulate in the blood and bind to receptors on immune cells, such as mast cells or basophils. When the allergen is encountered by the person again, it binds to the IgE antibody already stuck on the surface of the immune cell, triggering degranulation, which releases a variety of inflammatory mediators, such as interleukin 4, interleukin 5, and interleukin 13, that were in the immune cell, and they release into the person's bloodstream. These mediators then travel through the body and cause inflammation in the airways, which results in symptoms such as cough, wheeze, dyspnea, and chest tightness. When a patient presents with asthma symptoms, there are many tests that may be done to confirm or eliminate asthma as a diagnosis. As mentioned before, there is yet to be a single diagnostic test for asthma. If a patient does have asthma, their chest X-ray is usually normal, although hyperinflation may be observed. Their ECG is usually normal, eliminating suspicion of any cardiac involvement. They may have an arterial blood gas test, which is used to assess lung function and how well oxygen is being distributed throughout the body. If the patient's lung obstruction is significant, they cannot exhale CO2, and their CO2 will be high, which is called respiratory acidosis. They may also have a blood test with two specific findings in mind. Firstly are eosinophils. As mentioned before, activated eosinophils release substances in the lungs which cause inflammation. Secondly is IgE. As mentioned on the previous slide, when the body encounters an allergen, the immune system produces IgE to fight it. This leads to allergy symptoms such as sneezing, itching, as well as an increase in asthma symptoms. We're going to dig a little bit deeper into pulmonary function testing in the following slides. Spirometry is a lung function test that measures how much air a person can exhale after maximum inhale and how quickly they can do so. The patient will be asked to withhold bronchodilator medications before the test. A nose clip will be fitted and a good lip seal is required around the mouthpiece. The technician will instruct the patient to take a deep breath in, filling the lungs completely. Once filled suitably, the technician will instruct the patient to quickly and forcefully exhale until no more air can be expelled. The test is repeated at least 3 times. The test may then be repeated after the patient has taken their bronchodilator medication to assess whether there is any difference in the measures and therefore whether the patient's level of airway obstruction is reversible. To complete spirometry testing, the patient must be well and non-symptomatic. Normal reference values are based on matched individuals for sex, age, weight, height, and ethnicity. There is lots of information that can be obtained from spirometry assessment, but the ones that we are most interested in as speech pathologists are likely to be those that I have listed here. FEV1 stands for forced expired volume in 1 second. It is a measure of the total volume expired in the first second of maximal expiration after maximal inspiration. It indicates the severity of airflow obstruction. FVC, or forced vital capacity, is the maximum volume of air that can be exhaled during forced expiration after maximal inspiration. This provides information on lung capacity. FER, or forced expiratory ratio, represents the percent of lung capacity measured by the FVC that can be exhaled in 1 second, measured by the FEV1. A value below the norm can be indicative of obstructive lung disease. FIF 50 is the forced inspiratory flow at 50% of vital capacity. A lower FIF 50 indicates reduced inspiratory flow and can be indicative of ILO. TLCO is the transfer factor of the lung of carbon monoxide. It measures the movement of oxygen from the lungs to the bloodstream. Lung diseases are often categorized into obstructive or restrictive, although a mixed pattern is also possible. When someone has an obstructive disease such as COPD or asthma, the narrowing, inflammation, contraction, or collapse of their airways impacts the lung's ability to expel all of the air. This can lead to lung hyperinflation or air trapping because they have residual air in their lungs even after expiration. Because they have so much residual air in their lungs, they don't have much free volume when taking another breath in above what they already have. So for example, if you were to take a breath in and then try to take another breath in on top of that, that is what it feels like for patients with obstructive lung disease. The total lung capacity in these patients is increased. Their FEV1 is significantly reduced because they have difficulty getting air out in the first second of expiration. Their FVC is only slightly reduced and their ratio is below normal. In patients with restrictive lung disease, their lungs are stiff or fibrotic. Their lungs have reduced compliance, and because of this, it takes a lot more effort to get the lungs to expand, and so their total lung capacity is reduced. These patients have a slight reduction in FEV1, their FVC is reduced more significantly, and their ratio will be normal or high. When a patient has an obstructive lung disease, we want to know whether the obstruction is fixed, like in COPD, or reversible, like in asthma. To do this, bronchodilator is given to relax the smooth muscles of the airway, then spirometry testing is conducted again. The measures are compared. The FEV1 is expected to improve. However, if the FEV1 increases by less than 12%, then the airflow obstruction is considered fixed, like COPD. If the FEV1 increases by 12 or more %, then the obstruction is considered reversible, like in asthma. Flow volume loops are graphical representations of spirometry results. They show a complete respiratory cycle starting at 0. As the patient exhales forcefully, a peak is recorded, followed by the curve descending as the lungs empty. After exhalation, the patient inhales, which is seen as the loop returning in on itself in the negative portion of the axis. Flow volume loops also provide a visual representation to help understand overall lung volumes, whether the issue is obstructive or restrictive. In obstructive lung diseases like asthma, a dipped expiratory curve would be seen, resulting from exhaled airflow limitation. In patients with possible upper airway obstruction, there is a flattening of the inspiratory curve, which is shown underneath the x-axis. Inspiratory data in the flow volume loop is often overlooked, but can encourage referral to speech pathology for further assessment. Now we will go into more detail about asthma treatment. Comorbidities are medical conditions that exist concurrently with a primary diagnosis, in this case asthma. The presence of comorbidities are associated with worse asthma outcomes for patients with asthma. Treatable traits is a method of performing multidimensional assessments, examining pulmonary, extrapulmonary, and behavioural factors that are contributing to a patient's symptoms. A trait is a factor that can be measured, is clinically relevant, and treatable. The recognition of the traits of an individual allows for the implementation of personalised treatments. These might include specific medicines or speech pathology, and these would be according to the traits identified. The figure on this slide from Clark et al. In 2017 details the frequency of the most common traits observed in patients with asthma. This study indicated that almost 17% of patients with asthma also presented with inducible laryngeal obstruction. There are a wide variety of medications that are used individually or in combination to treat the symptoms of asthma. Reliever medications provide rapid relief from asthma symptoms and are used on an as-needed basis. They quickly relax the muscles around the bronchi to improve airflow. Reliever medications should be used at the lowest dose and frequency required, and if they are being used more than recommended, a medication review by a doctor is suggested. Historically, salbutamol, also known as Ventolin, was commonly prescribed. However, data demonstrating that it did not reduce mortality has led to the implementation of an inhaled corticosteroid plus a rapid onset long-acting beta agonist as the first line for reliever medication. It is important to be aware that people can still purchase salbutamol and Ventolin over the counter without a prescription or proof of asthma diagnosis. Use of short-acting reliever medications in isolation, even for mild asthma, has not been recommended in the latest global initiative for asthma guidelines. Frequent use of reliever medication with persistent symptoms could also be indicative of other diagnoses, such as inducible laryngeal obstruction or dysfunctional breathing, and may be the reason for referral to speech pathology for assessment. The ability to create antibodies targeting specific inflammatory targets has enabled the treatment of asthma endotypes using biologic therapies. These medications typically end in UMAB and are given via subcutaneous injection every few weeks or via IV. They may be taken in conjunction with other asthma medications. Patients require multidimensional assessment and blood work to help determine the appropriateness of this treatment, as well as the specific medication that will work best for them. A detailed table of the biologic medications available in Australia and their targets, their mechanisms of action, and indications is included in the accompanying educational document. Oral corticosteroids are usually given during an exacerbation of asthma symptoms. They typically end in zone, like prednisone, and are given orally or by IV. They are for short-term use only, as the risk of serious side effects increases once someone exceeds the lifetime exposure of more than 1,000 milligrams. This is the equivalent of 4 standard 5-day courses of OCS in a lifetime. Oral corticosteroids work within 2 hours to reduce swelling in the airways. They are absorbed by the blood and transported all over the body, leading to widespread side effects. Alternatively, inhaled corticosteroids are inhaled directly into the lungs. Spacers are recommended to improve the amount of inhaled asthma medications that get directly into the lungs. Worsening symptoms are often attributed to incorrect use of inhalers because they are thought to be easy to use. Often patients are not provided with adequate training. Approximately 68% of patients do not use their inhalers correctly, with approximately 67% of medical staff unable to demonstrate or explain the salient steps of inhaler use. Also, a quick note on oral care. People with asthma are at greater risk of tooth decay and gum disease due to increased oral breathing and medication side effects. Medications can cause a decrease in saliva, and oral bacteria can become acidic. It is important to encourage patients to rinse their mouth after using their steroid inhaler, using their spacer, and drinking lots of water. This is a great resource that you can find on the website of the National Asthma Council Australia of different inhalers and their technique checklists. This is another great resource from the National Asthma Council Australia. It is an outline of all the different asthma medications that patients may have, and a great resource to have on your treatment room wall if a patient is having difficulty remembering what medications they are taking. The National Asthma Council of Australia also has some great how-to videos demonstrating correct device technique for inhalers as well as nasal sprays. The following section of this presentation will detail specific information for speech pathologists on the assessment of patients with laryngeal dysfunction and asthma. Further information can be found in the related educational document. Questionnaires completed by the patient are commonly used to measure the nature and severity of symptoms and monitor progress during therapy. Some questionnaires commonly used in voice and upper airway disorders that may be familiar to speech pathologists are included on this slide. The Asthma Control Questionnaire may be less familiar to speech pathologists. It contains 5 questions about current asthma symptoms. Scores on the ACQ-5 range between 0, totally controlled, and 5, severely uncontrolled. Scores of more than 1.5 indicate poorly controlled asthma. Patients may have elevated ACQ scores if they misattribute symptoms of inducible laryngeal obstruction to asthma. Another questionnaire that speech pathologists may be unfamiliar with is the Nijmegen questionnaire. It is a 16-item screener for the presence of dysfunctional breathing patterns, specifically hyperventilation. It does not confirm the presence of dysfunctional breathing specifically, but despite this, it is the most used diagnostic tool in the dysfunctional breathing population. A score of more than 23 suggests the presence of hyperventilation syndrome and may indicate to the clinician that further assessment of the patient's breathing pattern is warranted. Taking a comprehensive case history is standard practice for any speech pathologist, so we will not revisit those details in this presentation, but it is outlined in more detail in the accompanying educational document. There are specific things that are important to remember when taking the history of a patient with asthma. Discuss specifics related to asthma, including how and when asthma was diagnosed. If referred to speech pathology by a respiratory physician, the asthma diagnosis has usually been confirmed by diagnostic testing. In other cases, the diagnosis may be less certain. It is important to address asthma medications, dose, devices used, and asthma control. This includes exacerbations and effectiveness of the asthma medications in controlling symptoms. Be aware that people can access Ventolin over the counter at their pharmacy without a prescription. Therefore, they may be taking Ventolin without a diagnosis of asthma from a respiratory physician. It is common for patients to report that their symptoms do not respond to asthma medication, which might suggest co-occurring inducible laryngeal obstruction. It is also important to know how many puffs of asthma reliever are needed, how often, and if the patient regularly requires more than their recommended dose. Asthma severity is also important to know. Inhaler technique, and when discussing the patient's other medications, specifically note use of ACE inhibitors, beta blockers, and allergy medications. Note whether the patient has any allergies specifically to non-steroidal anti-inflammatory medications, such as ibuprofen. Identify whether the patient's medical history includes other inflammatory conditions like dermatitis or nasal polyps. The following slides will cover speech pathology treatment of laryngeal dysfunction in patients with asthma. It is well known and accepted that speech pathology intervention is effective for laryngeal disorders co-occurring with asthma. There is little evidence regarding therapy dosage, however, between 2 and 6 sessions are commonly provided. There are 4 components to the speech pathology intervention: education, reduction of laryngeal irritation, symptom control exercises, and psychoeducational counselling. We are going to break these down in more detail. Education is a very important aspect of speech pathology treatment. It needs to be tailored for each patient and revisited regularly. Patients can often be overwhelmed with the amount of information they are provided during a session, so it is helpful to provide handouts and written support that they can take home with them and read in their own time. Some common things to touch on when educating patients with co-occurring asthma are the difference in symptoms and physiology between asthma and laryngeal dysfunction, the link between laryngeal dysfunction, asthma, and dysfunctional breathing, and the overlap in symptoms which can make diagnosis difficult. When a patient has inducible laryngeal obstruction, the glottis may narrow on inhalation, which can influence the transit of inhaled asthma medications into the lower airway. The patient may benefit from using breathing techniques provided by the speech pathologist before taking their inhaled medications to optimize vocal fold abduction. Compensatory breathing or muscle tension patterns can develop over many years and can be changed and improved. You may want to educate them on what the role of speech pathology is for in those with asthma and laryngeal dysfunction. The use of visuals such as models, diagrams, and videos is often helpful for patients to understand anatomic conversations. The impact that concurrent laryngeal dysfunction can have on the perception of their symptoms. If cough is a key symptom, it is helpful to explain the protective mechanism for cough and the hyperresponsive aspect to cough. This includes the cyclic nature of cough and perpetuation of laryngeal irritation. This strategy aims to prime the patient for cough suppression therapy if required. If the patient has had a laryngoscopy, it's beneficial to show the video to the patient. Laryngoscopy can also be used for biofeedback. Alternatively, diagrams and online videos of laryngoscopy in patients with and without inducible laryngeal obstruction or muscle tension can be shown. One of the simplest ways to reduce laryngeal irritation is by optimising the patient's hydration. Try extra humidification by inhaling steam. Work with the patient to develop specific strategies that will fit into their daily routine and help them to develop good hydration habits. Encourage them to breathe through their nose to avoid drying the laryngeal mucosa. Empower the patient to recommend their own strategies that will work well within their day-to-day life. Recommend that the patient sip water frequently throughout the day. Provide education on the impact of dehydration, both systemically and locally. Recommend that the patient drink sufficient water over the course of the day. It is also important to reduce laryngeal irritants by avoiding excessive caffeine and alcohol, optimising reflux treatment if needed, avoiding use of medicated lozenges, discuss current smoking or vaping habits, discuss treatments for postnasal drip or sinus issues, discuss sleep issues, identify and address triggers, and provide education on addressing their vocal load. The following are some specific techniques that could be used to target the 4 primary symptom areas of breathing, cough, voice, and laryngeal sensation. This is not an exhaustive list, and you might find that you need to trial several techniques to find one that works best for your patient. Much of this is in more detail in the educational document. There are several voice therapy techniques that could be used in individuals with asthma and co-occurring dysphonia, and some are included on this slide. It is unclear whether any one technique is better than any other, and there are no known voice therapy techniques that are contraindicated in those with asthma. Some of the most common strategies to address increased laryngeal sensation are outlined on the slide and have already been addressed in this presentation. Mucus can also be a recurring issue when working with patients with asthma and laryngeal dysfunction, whether there truly is mucus present or impaired sensation, or a combination. Patients may be under the assumption that they need to cough up the mucus because they have asthma. You will need to review the patient's urge to cough versus their need to cough. Remember, the urge to cough is real, but the need is not. The effectiveness of speech pathology intervention depends on the patient's adherence to the treatment. The patient's acceptance of the information and their adherence to treatment can be influenced by the way the education is provided. Some of the recommendations given to patients during treatment may appear to contradict the patient's beliefs or the advice that they've already received from other health professionals, so they might need to relinquish previously held beliefs about their symptoms and strategies that they have previously employed. Often patients present with emotional stresses that need to be addressed. You can also try asking therapy priming questions to clarify the impact of symptoms on the patient's quality of life. This helps provide information about the patient's readiness for therapy. Treatment goals must be meaningful for the patient and clinically relevant based on the assessment results. They should be adaptable and may change over the course of the treatment program. They should be tailored to the individual and revised with the patient during therapy to promote consistent patient motivation and adherence to the recommendations. On the slide is a small example of a detailed table found in the associated educational document that matches possible assessment findings with possible treatment strategies to help guide a speech pathologist's decision-making. This is a list of just some of the resources that were used in the development of this presentation and the accompanying educational document. You can Google the terms here, which will take you to the websites for more information. Thank you for taking the time to watch this presentation. We hope you find it and the associated educational document helpful in your practice.